Alrighty, here we go. Hello everyone, and thank you for attending this program on how to scrub EOBs, fight back, and appeal denials. There's no audio taping or videotaping, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information contained in this presentation is for educational purposes. It's not intended to be a substitute for your clinical decision making. It's not intended to be legal advice. Target coding does not engage in providing legal services. If we talk about CPT codes, just a reminder, CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Just a little bit about myself before we get started. My name is Dr. Marty Kotler. I am a chiropractor. I'm also a certified professional compliance officer. I'm certified in CPT coding. My areas of expertise include coding, HIPAA compliance, documentation, compliant care plans, how to manage care, and Medicare. I've written many compliance and documentation training manuals. I write articles for chiropractic economics and dynamic chiropractic. I speak for the Coding Institute, Parker Seminars, Foot Levelers, and I'm a guest speaker at many state association conventions nationwide. So there are many reasons why claims can get denied. We're going to go through a few today. So let's start off with the most common one. The services rendered were not medically necessary. Now this is a very broad statement that many carriers will provide to you on an EOB, an explanation of benefits, for a variety of reasons. Just to give you some real simple ones, if you do not put the patient's proper information on a SOAP note and you send that information to an insurance company, they could say, oh, sorry, services were not medically necessary. If you don't write down, for example, with Medicare, if you don't write down the specific levels of subluxation, then they just equate that to not medically necessary. If you don't put if your notes are illegible, insurance companies can say, well, we can't read your notes. That equates to services not being medically necessary. If an insurance company asks you for your notes and for some reason you don't send them in, they equate that to, well, we don't have the notes, then the services are not medically necessary. So it's a very broad term, medical necessity. So what is medical necessity? It's a very broad question too. Well, it depends who you ask. Let me just go over a few things regarding medical necessity and wellness care or maintenance care. So you could look at it like this. Medical necessity, that equates to a service being insurance payable. I mean, just think about it. If an insurance, a patient, some patients will call their insurance companies prior to coming into your office to check and see if chiropractic is covered. So you could have a patient call up to their plan and say, hey, what type of benefits do I have for chiropractic care? And the insurance companies will oftentimes say, well, you're covered for chiropractic care as long as it's medically necessary. And then they may give a limitation. So we'll cover 20 visits as long as it's medically necessary. We cover $1,000 worth of chiropractic as long as it's medically necessary. Some insurance companies will say, well, it's unlimited care as long as it's medically necessary. So medically necessary typically means insurance payable. Chiropractic wellness care, maintenance care, supportive care, that's not payable by insurance. If you treat a Medicare patient and you consider that patient to be under active treatment, that's payable by Medicare. That's medically necessary. So pain, restricted motion, decreased activities of daily living, that equates to insurance payable. After 10, 12, 15 visits, however many visits, when that patient reaches maximum therapeutic benefit where they have very little pain, range of motion is pretty good, they can do most of their ADLs, then that service becomes not insurance payable. Not medically necessary also means not insurance payable. Performance-enhancing care is not payable. What does that mean? You could have a patient come in that, let's say, plays golf and says, I feel great, Dr. Kotler. When I tee off, I hit the ball 200 yards. I heard you're really good at getting people to, hit the ball further. You've helped some of my friends. I want to be able to hit the ball 225 yards. Can you help me? Sure, come on in. Well, that's not insurance payable care. That's performance-enhancing care. So the trick is at maximum therapeutic benefit to transition the patient to wellness. Chiropractic necessity versus medical necessity is different. You can consider something clinically necessary. That doesn't mean it's insurance payable. So again, medical necessity, it depends who you ask, right? So if you ask Aetna, they'll say that it is. Chiropractic care is medically necessary. If the patient has a neuromusculoskeletal condition, the treatment is clearly documented, improvement is found within 2 weeks. And then it says, once maximum therapeutic benefit has been achieved, chiropractic care is not medically necessary. So that's why if you send your notes to Aetna and they review them, they may come back and say, sorry, not medically necessary. Cigna also has a policy on medical necessity. You should go get it. If anybody would like it, just send us an email. We'll send you the Cigna chiropractic medical policy. CMS has a definition of medical necessity. It's a treatment that is required to identify an illness or an injury. It's consistent with the patient's symptoms. It's appropriate under the standards of care. It's not solely for the convenience of the patient or the doctor. It's the most appropriate service or treatment which can be safely provided to the patient and accomplishes the desired end result in the most economical manner. And then you have Medicare. Medicare has their own definition of medical necessity as it relates to chiropractic, and there are 8 Medicare carriers across the country that cover all 50 states. And then you have Blue Cross Blue Shield. They say, yeah, most plans cover chiropractic when it's performed at the expectation of restoring the patient's level of function, and your chiropractic care must be in accordance with a written treatment plan. All right, let's move on to the next denial that you may get. Number 2, benefits are denied because the patient has reached maximum medical improvement. That could be similar to we feel that the patient has reached the point where the care is not medically necessary, so you need to use good fight back letters. Here's a sample letter we provide to our clients. If anybody would like this letter, just send an email to info@targetcoding.com. And this says, I am writing this letter of appeal in response to your explanation of benefits that states our documentation does not support medical necessity. I respectfully disagree with the reviewer that made this decision. The clinical support documentation does clearly show that the patient has dramatically improved because of the care rendered in this office. The chart records do indicate that chiropractic care did provide lasting benefits, and although the patient has made significant improvement, she still needs additional care. The below information will provide you with the clinical rationale for you to understand why we feel the care provided in this office was medically necessary, and we hope you overturn your decision and authorize care. Let's go for another one. Number 3, the service is denied because it was incidental to the major service rendered. Yeah. CAs listening to this presentation right now, you're all probably shaking your head. Yeah, I've seen that one where they bundle. It's called bundling. You send a insurance company 2 codes and they decide to bundle the 2 together and only pay you for one. The 2 most common ones I see in chiropractic is where they bundle the re-exam with the chiropractic adjustment, and they also bundle the manual therapy with the chiropractic adjustment. So that's why you want to make sure that your chiropractic adjustments are separate and distinct than everything else. Your exams are separate and distinct. So if you do a re-examination on a patient and you also do a chiropractic adjustment, what are you going to do? You're going to put the 25 modifier on the 99213, for example. That's a re-exam code or an established patient E&M code to designate that it's separate and distinct. So that's the first thing I look at when a client of mine sends me an EOB. and they bundled the re-exam, or the doctor or staff says, Marty, we sent in a claim for a re-exam and an adjustment, and the insurance company bundled the adjustment, bundled the adjustment with the re-exam and didn't pay for the re-exam. I go, okay, let's take a look at the claim. Let's take a look at the notes. Let's troubleshoot it. That's what we do all day here at Target Coding, helping our clients across the country troubleshoot and get paid the maximum amount allowable. First thing I'll look at is the 25 modifier on there. It could be as simple as that. Left off the 25 modifier, resubmit it, then there you go. Resubmit it, and then you can get your claim paid. It could be as easy as that. Next, did you make that re-exam separate and distinct? For example, when the patient came in on that day, did they show a reason for the re-exam? Did they come in and say, hey, Dr. Kotler, I have a new problem. I have a flare-up of an old problem. I think I got worse. That could help substantiate the reason why you did the re-exam. See, some insurance companies, when they look at a re-exam, if they have the notes especially, they can go, well, this visit looks like a regular visit. Why did the doctor bill a re-exam? So make sure you make it very clear in your notes that if you billed for an established patient E&M code, that there was a specific reason for doing it, like a flare-up, a change in condition. The patient got substantially better. Patient got worse. Also, very common, the chiropractic adjustments in manual therapy. If you bill a chiropractic adjustment and manual therapy without the 5-9 modifier, they'll typically bundle the two together. If you bill with it and you still get denied, well, did you show that it's in a separate and distinct region? So the 5-9 modifier and the 25 modifier, those are rare modifiers that bypass the CCI edits. Well, it's more about the CMT and the 97140 with the bypassing of the CCI edits, because there is a CCI edit, correct coding initiative edit, on those two codes. So if you get one of those, then have a good appeal letter. So this is a sample appeal letter when the insurance company denies the re-exam on the same day as the chiropractic adjustment. And you want to use reliable sources when you're fighting back. So here, dear insurance company, this letter is in response to your denial for the E&M code, the 99213, that we billed on Mr. Patient. We appreciate the time you took to analyze our claim. However, we disagree with your decision. The E&M procedure was not an integral part of the chiropractic adjustment. According to the AMA, here we go, we're quoting reliable sources. According to the AMA, is that a reliable source? Yes, it's probably your best source if you're fighting on a CPT code. If you use the AMA to back up your argument, you're going to win. Unless it's a non-payable code. That's a whole nother story. We'll get to that in a few minutes. So, according to the American Medical Association, under the chiropractic manipulative treatment section, that's what they call chiropractic in the AMA, CMT, chiropractic manipulative treatment, it says additional E&M services may be reported separately using the 25 modifier. Mr. Patient presented with new and significant identifiable condition. He had an exacerbation of low back pain. Take a look at my notes. You'll see what I did. Okay, let's go to number 4. Payment will be considered upon review of the chart notes. Yes, well, you may have been put into a prepayment audit. You may be treating personal injury. Most PI carriers require that you send in your notes with your bills. If you don't, you may get this denial. Payment will be considered upon review of the notes. If you're put into a prepayment audit, I know quite a few doctors, unfortunately, or it might be fortunate, I don't know. Sometimes with a prepayment audit, with some doctors, it might be a blessing in disguise because you have to send in your notes with your bills. If you do that and you get paid, then you don't ever have to worry about a post-payment audit because they've already approved payment based on your notes. So that's the positive part about it. The negative part is gathering the paperwork, sending it in, and waiting for payment. So if you get payment will be considered upon review of the chart notes, my recommendation is send in the notes. Now, if you're a cash practice and you ignore it, that's a little risky because now the patient might not get reimbursed. And if the patient doesn't get reimbursed and they have insurance that covers chiropractic, it will decrease the chance of them coming in. They just want to recoup the money they're paying you. Can't blame a patient for that. Number 5, the service is denied because it is included in the contractual obligation and the patient may not be billed for the service. Please be careful with this. There are some services when you are in network that even though you consider it medically necessary, the insurance company may not consider it medically necessary. And if you're in network, you cannot charge the patient for the service. So there's pros and cons to being in network, pros and cons to being out of network. So let's just go over a few of those. Now, let me just reiterate that scenario. If you charge an insurance company for what you consider a medically necessary service, and the insurance company says, we do not feel it's medically necessary, you're not supposed to just go to the patient and say, hey, Mr. Jones, your insurance company didn't pay, you have to pay. That would be a violation of your contract. Make sure you know your contracts. Those of you that are members of Target Coding, send us your contracts. We review them for you. Now, yes, pros and cons to being in network, pros and cons to being out of network. You should know that. Now, I'm not telling you to become participating provider with any plan. I'm not telling you to drop out of any plan. This is a business decision. Again, pros and cons to being in, pros and cons to being out. There's credentialing. Usually many in-network plans is a two-step procedure. First is credentialing. Make sure you are who you are and do a little check on you, and then you get into contracting. Your fees are going to be different in-network and out-of-network. Deductibles, co-pays, co-insurance could be different in-network versus out-of-network. You know, I get a lot of students working with us here at Target Coding, and one of the first questions they ask when they get out of chiropractic college when they hire me is, Dr. Kotler, should I go in-network or out-of-network? I love working with students. So in-network or out-of-network? So I typically ask the student, well, when you open up your practice, do you think you're going to have some trouble getting new patients? You know, some students don't have an issue. They're magnets or they're taking over practice and they get a lot of new patients. If you're a student opening up a new practice coming up and you're not sure about new patients, my recommendation is get in all the plans. Sign up for every single plan in your area. Go through the growing pains. You'll get new patients. You're going to get more new patients. And if you don't like the way it's going, after a few months, you could always drop out. So if you're not sure, I say get in. Test the waters. You could always drop out. So in-network, out-of-network, the claims get processed differently. Out-of-network, you can have more freedom. You can charge your patients your full fee. So what's covered, what's not covered is an important part. So when you're in network, if you perform a service that's considered a not medically necessary service or a cash-based service like vitamins or laser, most in-network plans don't pay for it. Then make sure you're charging cash to maximize reimbursement on that. Let's go to number 6. Benefits are denied because the diagnosis is inconsistent with the procedure. Here's where a situation where the insurance company has decided to see if your diagnosis codes are matching the procedure codes. I call it code pairing. Let me give you an example here. It's almost like pairing food with wine. You know, I go to couple of wine and food festivals every year. I enjoy them, learning about how to pair wine with food, red meat with red wine, and white wine with fish, typically seafood. So do the same thing with your coding. You want to pair your diagnosis codes. For example, a patient comes in and you diagnose the patient with some sort of cervical disc problem or cervical radiculopathy or lumbar disc degeneration. Well, those diagnosis codes pair beautifully with mechanical traction, 97012. Have a patient come in with sciatica, neck pain, shoulder stiffness, quadriceps strain. Those pair beautifully with therapeutic exercises. Patient has myofascial pain. Now we're talking about more soft tissue conditions here. Myofascial pain, bursitis of the hip, also disc issue. Those pair beautifully with manual therapy, 97140. Here's a claim that also helps you link and point. You may have heard of diagnosis pointing. So in the scenario you see on your screen, you see the 98940 is the procedure code. So what are we linking that? What are we pairing that with? The codes in A and B. A is a disc problem in the lumbar region, and B is spasm. What else did we do? 97140 with the 59 modifier. That's linking or pairing or pointing to the two codes in positions C and D. C is cervical radiculopathy, and D is myofascial pain. Beautiful. That links with manual therapy or myofascial release. Next, we did unattended electrical stimulation. We're pairing that with the two codes in E and F. E is thoracic disc degeneration, and F is mid-back pain. And then we have 97110, and we're pairing that with the two codes in A and B. We're pointing back to the two lumbar problems with the lumbar disc and the muscle spasm of the lower back. So that's an example of how to pair your codes. Oh yeah, there's a book that I recommend. It's called The Best CPT ICD-10 Code Combinations to Maximize Reimbursement. So here's an excerpt out of the book for therapeutic exercises. It gives you the clinical rationale, and then it starts giving you all the diagnosis codes. These are the cervical region, and they're in the book. It lists the thoracic, lumbar, extremity regions. All right, let's go to the next one. Benefits are denied because the diagnosis is not substantiated in the patient records. Okay, because of ICD-10, the diagnosis justification is more important than ever. Insurance companies are looking for you to specify and justify the diagnosis code. So here, I took an example. Let's say you diagnose a patient with a sacroiliac sprain. Sure, it's pretty common in chiropractic, sacroiliac sprain, sacroiliitis, a sacroiliac joint subluxation. Something's going on with the sacroiliac joint. Pretty common in chiropractic. So let's say you diagnose sacroiliac sprain. That's ICD-10 code S33.6. Okay, you submit the claim. Now you get questioned by, let's say, an insurance company case reviewer, or maybe a malpractice case, or a patient files a complaint against you with the state board. You're going to have your records requested. So regardless if it's an insurance company, a state board, malpractice carrier, your question, Dr. Kotler, we see that you diagnosed a patient with a sacroiliac sprain. How did you come up with that? What led you to that decision? Hopefully you'll have a good answer. Like, here, I'll share with you. Well, the subjective findings, the patient stated that he had pain in his SI joint. Orthopedic tests included Yeomans and Ganslins. There you go. Those are the gold standard tests. If you are going to submit a diagnosis with anything relating to the sacroiliac joint, I would recommend your examination findings show that you performed a couple of these ortho tests like Yeomans for Bear-Patrick's, Knocklis. And then your chiro findings, there was some palpatory tenderness in and around the SI joint. There may have been some swelling, hypermobility, hypomobility. Let's take another example. Let's say you diagnose a patient with a cervical radiculopathy, and now your question, Dr. Kotler, how did you come up with that? Hopefully you'll say, well, the patient had pain radiating from the neck into an arm. I did Valsalva, Sperling, Jackson compression, a couple of orthopedic neurological tests. I checked reflexes. There was some myotomal weakness. There was limited motion, subluxations. So make sure that you do this. It's important now more than ever with ICD-10, and it will prevent denials and claim rejections. Oh, yes, and I had mentioned a book that I recommend on the ICD-10 CPT code book to maximize reimbursement. This is another excerpt out of the book where it talks about the actual diagnosis, and then it gives you the ortho, neuro, chiro findings like cervical brachial syndrome at the bottom. Ortho, Deuce, Wright's, Atson's, a couple of these ortho tests, diminished sensation, forward head posture. These will help you justify and prove that the diagnosis codes that you are using are justified by your ortho, neuro, chiro tests. Next, procedure is being denied because it is not typically performed on the same date of service as the other billed procedure. Here we go. Yes, I had mentioned CCI edits. The CCI edits refer to the Correct Coding Initiative. This is a federal program that maintains a system of coding edits. The purpose of these edits is to electronically codes billed together that would not normally be used together. So in chiropractic, the CCI edits, there are thousands and thousands of these CCI edits. The ones that pertain to chiropractic, one of the main ones that pertain to chiropractic are that, well, the CMS says that manual therapy, massage, and neuromuscular, so manual therapy 97140, massage 97124, and neuromuscular 97112 cannot be performed in the same anatomic site as the chiropractic adjustment. So if you do it in a separate site, that's fine. Put the 59 modifier on it in order to indicate that it's a distinct procedure and it's being performed on a different anatomic site than the chiropractic manipulative treatment. Now, the CMS CCI edits state that all three codes are not supposed to be performed in the same anatomic site as the adjustment, but the AMA differs. The AMA came out with their opinion a few years ago, and they said, well, chiropractic adjustments and massage and neuromuscular can be performed in the same anatomic site, but they did agree that manual therapy is a duplication. It doesn't make sense to me, and I know I'm preaching to the converted here. It's so silly, but these are the rules. I don't make the rules. I just explain them to you so they make sense to you somewhat so you could incorporate them. And you need to know the rules in order to know if you're following them or breaking them, right? But it really doesn't make sense. If a patient comes in, with neck pain and you want to do some manual therapy on their neck, some myofascial release, and then you want to give the patient a chiropractic adjustment in the same region, what's wrong with that? I don't see anything wrong with it. I'm sure you all agree with me, but the CCI edits have a problem with it. So be careful with that. And one more here. You get a denial because the insurance company said, oh, your modifiers are wrong. They're missing. They're invalid. Very common too. You know, and there are many, many more of these, but we're just about out of time now. So the 25 modifier must go on your E&M codes, like your exams and re-exams, in order to show that they're separate and distinct. So the 25 on exams and re-exams. If you do anything on the same day as a chiropractic adjustment, like an exam, use the 25. The 5-1 is typically on the extremity manipulation if the carrier requires it. Less and less carriers are requiring the 5-1 on the extremity adjustment, 98943. See, many years ago, insurance companies would deny the extremity adjustment on the same day as a spinal adjustment, saying they were inclusive of each other, and then a decision was made, well, we're going to put the 5-1 on the extremity to show that it's separate and distinct, and that worked. So many carriers require it, some don't. More and more are not requiring it. So either way, with the 5-1 or without the 5-1 is a compliant billing. You just want to try and submit it properly in order to get paid. Just like with Medicare, if you bill Medicare 98940 without the AT, you're not going to get paid. With the AT, you will get paid, but the 98940 portion was correct. Back to the screen, 5-9, we discussed the 5-9. That's a separate and distinct, most commonly put on those three codes that have the CCI edits, the manual, neuromuscular, and massage. AT is for active treatment. When you bill Medicare, in order to get paid for spinal manipulation, you must add the AT modifier. If not, you won't get paid. So the AT modifier, those two little letters, A and T, it tells Medicare a lot of information. It tells Medicare that you understand the Medicare guidelines, you have subluxation as a primary diagnosis, and you have supporting secondary diagnosis codes, you did the part exam, all of that, just with the AT modifier. GA modifier means you have a signed ABN form on file. Again, you don't have that. It can lead to problems if you submit with the GA modifier and you don't have an ABN form signed on file. That could be an issue. And the GY is another Medicare modifier that I recommend you put on all the non-spinal manipulation codes like exams, x-rays, and therapies. All right, just a few closing comments. Please check with all the carriers you bill prior to submitting claims based on this information to ensure that it is compliant. Target coding does not guarantee that this information will guarantee payment from any insurance company or patient. Target coding is not responsible for any rules that may change following this presentation. You know they change all the time, right? So do your best, attend seminars, webinars, join your national and state professional associations. Here's our contact information. Email info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. Fax number, we have a HIPAA secure fax number, 1-844-831-2347. Oh, this is the book that I was referring to, The Best Chiropractic ICD-10 and CPT Codes to Improve Reimbursement. This is the book that has the yes, it has the long-term treatment diagnosis codes. For example, sciatica would be considered a long-term treatment diagnosis code versus muscle spasm or muscle strain. So this book has the long-term treatment, moderate-term treatment, and short-term treatment diagnosis codes. There's a section on frequently asked questions. Like I'm often asked, Dr. Kotler, what's the difference between disc disorders and disc displacements? What's the difference between effusion, swelling, and edema? What's the difference between cervical brachial syndrome and cervical radiculitis? What's the difference between spasm and contracture? What's the difference between myalgia, myositis, and myofasciitis? A whole bunch of questions there that you might be curious to know the answers to. And there's some cheat sheets, and this is the section, yes, I showed this earlier, on how to pair your codes together. Oh, at Target Coding, we also offer compliance manuals. If you treat Medicare patients, you are required to have an OIG. OIG stands for Office of Inspector General compliance manual. It should consist of your personal policies and procedures, how you conduct internal audits, sample training logs. You should be logging in your trainings on your Medicare patient files. We offer that. Here's a little chart audit tool. You're supposed to do an internal audit. If you're ever audited by Medicare, one of the questions they may ask you is if you do internal audits. So we have this little checklist. That's part of our OIG manual. Little spreadsheet. You go down, look at your notes. Yes, no, yes, no. Oh, we also offer HIPAA compliance programs here at Target Coding. Ours is a concierge type of service where we do most of the work for you. We charge more because we do more. Shop around. If you're looking for a HIPAA compliance program, make sure you're comparing apples to apples. Our program includes $100,000 of cyber liability insurance. You have a cloud-based storage portal where you have all your policies and procedures uploaded. We have compliance training videos for you and your staff members. You could even take tests and get certificates of completion. We can help you track your business associates. It's a one-year program. We fully support you for the whole year. The pricing depends upon how many employees you have. We also do seminars and tons of webinars. We have a whole bunch of seminars coming up. Check our website for our dates and locations. We also offer memberships. This is our basic membership. It's $99 a month. You just pay as you go. Ask questions. You can attend all of our live webinars at no charge. We do them just about every week, and most of our webinars are over $100, so if you just attend one, you've got your money back right there. And then we also offer a gold membership, which includes deeper training and review of your notes and your fees and your codes and all your forms and monthly support and all of our training manuals and access to the member-only section of the website. And then we have a Platinum membership, which includes an on-site training for you and your employees. If you're looking to just chat with us for 15 minutes to pick our brain, get more information, you can do that. Again, here's our contact information, info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044. Our HIPAA secure fax number is 844-831-2347. I hope everybody learned a lot. Thank you for attending.